Good evening, everyone, and welcome to celebrate Women's Health Week. Brisbane North PHN, in partnership with our Regions 2 Endometriosis and Pelvic Pain GP clinics, are pleased to present tonight's webinar for local health professionals on endometriosis and pelvic pain. My name is Amy Howard from Brisbane North PHN, and I'll be your host for this evening. I'd like to begin this webinar by acknowledging the traditional custodians of the lands on which we meet today and pay my respects to elders past, present, and emerging, and also acknowledge any Aboriginal and Torres Strait Islander people attending tonight's webinar. The beautiful artwork you see on the screen is part of Ricky Salam's Flowing Knowledge Healing Country and represents the PHN's vision for reconciliation. To ensure you get the most out of tonight's session, please ask questions via the monitored Q&A box. We will have time to answer questions after each presentation. However, we've also allocated additional time at the end. This webinar will go for an hour and a half, finishing at 8 p.m. And we'd love to hear your feedback on tonight's session. A survey will appear after the presentation finishes. And for those who are seeking RACGP points, we ask that you complete this as part of the educational activity. And for those who are unable to attend, a recording will be made available. In 2023, 2 clinics in the North Brisbane and Moreton Bay region were selected by the Department of Health and Aged Care to pilot new models of care to support individuals experiencing endometriosis and pelvic pain. And as you can see highlighted on the screen, we have 1 clinic in Brisbane and another in Moreton. And tonight you'll be hearing from the GPs, allied health providers and staff delivering these services to understand the unique model of care each clinic provides and gain insights into the lessons learned during their implementation. You can also view a full list of the participating clinics, that's nationally, by visiting the Department of Health and Aged Care's website via health.gov.au and searching endometriosis and pelvic pain. So here are our distinguished presenters for this evening. We have Dr. Sarah McDonnell, who's from Neighbourhood Medical, Marnie Pointer from Healthy Peach Physiotherapy, Dr. Helena Clare from the Moreton Aboriginal and Torres Strait Islander Community Health Service, and Keely Pasqua from the Institute of Urban Indigenous Health, all of which are involved in the endometriosis and pelvic pain pilot for Brisbane North PHN. So without further ado, I'd like to introduce our first speaker this evening, Dr. Sarah McDonnell. Dr. Sarah McDonnell is a GP and owner at Neighbourhood Medical in Brisbane. She's practiced as a GP for 20 years and has a special interest in women's health, including pelvic pain, menopause medicine, and IUD insertions. Sarah is the clinical lead at the Neighbourhood Medical Endometriosis and Pelvic Pain Clinic. She also has a master's in public health and is interested in health systems and funding and how that impacts access and health outcomes for communities. So over to you, Sarah.
Thanks, Amy. Welcome, everybody, and thanks for having me tonight. As Amy said, I'm the clinical lead GP at the Neighbourhood Medical Endometriosis and Pelvic Pain Clinic, and working within a team and in a virtual team with our allied health colleagues, including Marnie, who's going to speak after me tonight. I would also like to acknowledge the traditional custodians of the lands on which we meet today and pay my respects to their elders past and present, extending that respect to all Aboriginal and Torres Strait Islander people, including those present today. So, the scope of our talk tonight is going to be about our particular clinic and its services, access and how people can be referred into the service, what we have learned so far, and sort of practical tips for any GPs who may be attending, and resources and educational opportunities for GPs, practice nurses, and other primary healthcare workers who may be interested in developing services in this area. A little bit of background on endometriosis. I'm not going to go into this too much at the moment, but clearly it has been a hot topic for advocacy and action and a much needed area of action in recent years. It is a chronic inflammatory condition that can be painful, although it's not always painful, can affect fertility and can lead to significant impacts on quality of life. Hence the drive to help the many women affected by endometriosis, which is depending on which study you look at, around 1 in 7 women. There is a real need to improve care in the community for this population, as hospitalizations with endometriosis as a principal diagnosis are on the rise, particularly in younger women. Anybody who would like more detail on the background in the current Australian context, there's a link there that you can access. It is important to say that persistent pelvic pain is an entity in and of itself and does not always have endometriosis as its cause or as a comorbidity. And the key aim really of the clinic as we run it is to manage pain in the community, whether or not a person has endometriosis. The background to the 22 clinics that have been funded under the grant is that we are pilot programs funded by a commitment made in the budget in 22-23. 22 clinics have been chosen in various primary care settings throughout Australia, 4 in Queensland, and we're lucky enough to be one of 2 in the Brisbane North PHN. These are very varied contexts with varied funding models, and that impacts the type of care and services that are delivered by each service. We do have a virtual community of practice where the staff, including GPs, practice nurses, physios, and other health professionals who are involved in the clinic, collaborate and we get ideas from each other. The purpose of these clinics is to provide some insight into what services might work going forward in primary care. Funding is important to consider, as we are not in the private GP setting allowed to mix Medicare and grant funding service or grant funding for the same service, so that impacts our structure. We work out of a small private general practice with a focus on women and children's health. I established it with my co-owner, Dr. Nicole White, in 2020, and we now have 8 GPs, all female, and multiple with special interest in women's health. Our core values include creating a welcoming space where patients feel heard and understood, which is really a key part of the pathway to managing pain, and that trying to ensure our service is sustainable for the providers involved in providing the care, the practice, and the patients. And we like to have as many systems in place as we can to support this. This is a case, I guess, of where advocacy and cooperation between different areas of the health care sector and political sector can lead to some real, albeit small, impactful changes in the community. And I think we all need to optimize the passion that exists to improve services for women with pelvic pain and endometriosis in the community. What does this mean in practice? Like any funding, it really translates into time. Time with patients, less out-of-pocket costs for the patient. We have had the opportunity to do significant education in order to improve our abilities as providers in this space, and it allows us to improve collaboration with other primary care providers. Access, as in all primary care, is via self-referral. So we accept any referrals from patients who wish to refer themselves in. It is through a form available on our website, or it can be emailed out to patients. This form, I guess, can create, a barrier to access for some people. So our nurse navigator can contact anyone who's having difficulty navigating this aspect of the referral. GPs and other allied health and specialists can refer in. We can use the same form. They can send us a letter. It can be emailed to our dedicated pelvic pain email. So multiple access points, eligibility and safety criteria are considered, because we have neither the scope nor the clinical capacity to act as a de facto gynae clinic. These services are focused and specific for women with and those assigned female at birth with pelvic pain. We don't take online bookings so that we can control the pace and flow of the work and make sure that there's adequate time for everybody. Those who we don't see as eligible for our particular service include people with period pain that haven't tried any basic pain relief or hormonal options, although some people prefer not to use any hormonal options, so that's not a hard and fast criteria. Those who already have a good multidisciplinary team in place, including physio, psychology, and anybody else who needs to be involved. Those accessing the service looking for fertility treatments, as we have no expedited pathways in that area, nor do we have expedited referral pathways for laparoscopy. This is more about diagnosis and management within the community rather than accessing surgical services. We feel that it's not safe to manage those residing outside of Queensland due to barriers accessing local care. And currently we are not seeing people who are pregnant within the clinic. We saw our first patients back in September of last year. Well over 200 new patients have now come through the clinic, the large majority being self-referrals, although we are seeing increased GP referrals. When we set up the clinic, we theorised that there would be 3 main groups accessing the service, and actually most people have fallen broadly into one of these categories. So younger women with symptoms suggestive of possible endometriosis or with persistent pelvic pain requiring a diagnostic assessment as well as a management plan and team created. Those who have known endometriosis, diagnosed on laparoscopy, have had their surgery but have been discharged without a team approach in place to managing their pain. And the final group, patients with complex persistent pelvic pain who may or may not have endometriosis and frequently have multiple comorbidities and have had their pain for a long period of time. And data from our patient feedback forms collected recently show that we have a widespread across the ages and hence across those 3 groups of patients, and also a good geographical spread. Many have travelled over 20 kilometres. We do telehealth services to regional areas as well. And we do try to consider access within our capacity for groups who may find it difficult. We try to include appropriate language for all groups of patients. We are aware of our colleagues at the MATSICHS clinic so that anybody who would prefer a more culturally sensitive, specific type of care can be referred in that direction for Aboriginal and Torres Strait Islanders people. We would like to branch out more into those who do not have English as their first language. We have had many of those patients come through the clinic. The benefit for many is that because we are not accessing Medicare funding, we can provide services for people in the community who may be limited in that way. And the telehealth aspect to regional and remote patients has been useful. We try to have a trauma-informed approach across all our patient groups. The actual running of the clinic is across a virtual team in our clinic and our allied health clinic. We have 3 GPs on site and we work 2 dedicated pelvic pain sessions per week. Linchpin of our service is our nurse navigator, Shay, who does the intake assessment, collates all the information you may need from previous radiology or surgical reports, helps patients to navigate the system and finds out what each person's priorities are. We have our allied health team off-site, additional funded services, and try to arrange a multidisciplinary team meeting. So the first intake appointment with Shay is really, we found to be one of the most successful parts of the clinic, and it is something that the grant has really afforded us to do, which is have time with a patient to connect and hear their story. This is a 45-minute telephone or video appointment, so it's easily accessible from any location. People can take time off work to do it. It has actually made the intake assessment part easier. Shay is a long experienced practice nurse and has also done extra qualifications in pain and endometriosis. And her aim is to get to know the patient, figure out what their priorities are, find out any red flags that need to be addressed rather than waiting to see the GP, and really pull everything together. A mental health assessment is also undertaken as part of the intake assessment, and sensitive trauma-informed care, including taking a trauma history from anybody who does wish to disclose any aspect of that. These are the kind of points that are included in the intake assessment. We run it with an intake form that can be filled in on somebody's phone, so that we have the bones of the assessment before they start to speak to Shay, and she can really just then spend more time connecting and clarifying what a person's main priorities are. And then usually there's a number of weeks delay between the nurse and the GP appointments. This is because of the amount of people coming into the intake appointment. There is a slight drop off between that and the GP, but very little. It does give us time to collate information, sometimes to have scans done and arrange other necessary pieces of the puzzle before the patient sees the GP. we try not to spend too much time recapping history that has already been given in this time, but more just to connect and summarize and understand what the patient's main priorities are, and then create a management plan with a large focus on options, choice, patient preference, and education around pain and pain science, which is then followed on by our wonderful colleagues, who will speak later on that topic a bit more. We review diagnosis and treatment to date, so taking a generalist approach across not just gynecology, but gastro, mental health, many other systems. And an exam is only performed if indicated during this assessment. Many people have been well investigated, had laparoscopies. They don't need a GP to examine them to necessarily prove that they have pain. Any examination during this appointment will be focused on any clinical issues that are safety related or need to be clarified, and only with the patient's, consent and comfort in mind. We, as GPs and our share, we have all undergone pain training with the NOI Institute, so we try and provide an explanation for the patient's pain and or symptom complex using that kind of framework. The Pelvic Pain Foundation has been massively helpful in resourcing our clinics with patient education material and structured tools to use during the consultation. So we use this diagram that you can see here, and I always actually draw a big circle all around the organs and everything to say that this is all happening inside you as a person in your life, to start with the idea that there are many factors contributing to pain, not just whether or not there is endo there. And there are many tools and parts of the team that can be arranged to suit an individual to manage their pain. A very important concept is that pain is real, it's not in your head. A lot of the patients who come to our clinic have been given that message. So we talk about how pain centers in the brain can be seen on functional MRIs functioning differently in people with pelvic pain and other pain. That pain is a danger signal. So there may be something happening in your body that is harmful, but there may not be. It may be a sensitized system responding to potential danger from non-dangerous stimuli, and try to give some hope that we are plastic, our nervous system is plastic. So what is ramped up to send more pain signals can also be ramped down. And this forms the basis then for a plan moving forward. We talk about endometriosis and the nature of it, but we try not to focus solely on that because it may or may not be present depending on the patient and their history. And we do know that surgery, laparoscopy to define that may not reduce pain or remove pain, although it can. So to give a realistic expectation that endo may not be the answer to everything, and you can have real pain without it. We start off with non-pharmacological approaches, so basic building blocks, movement, exercise, sleep, find out where a patient is at and start the conversation about how we can start to use those to manage pain, as well as not avoiding normal activities that will not worsen the pain. Psychological approaches and stress reduction, again, individualized to each patient. Many will have a team in place already with a psychologist, and everybody gets referred on to our physiotherapy team. Offered a group education program if interested, and or individual sessions. It is up to the patient to then engage if they want to, and we find that there's a really good uptake of this. And we also have referrals onto exercise physiology and links with dietitians if needed. The TENS machine I'll come on to later. This appointment is an hour, so there's a lot. We write everything down. Nothing is said and not written down. We have a toolkit and team template and leaflets for everything go in a folder. They can also be emailed. Clearly, for people who might have literary difficulties, this might be a barrier, but we find that at least giving all the information, we can sift through it later. We try to create a flare plan with appropriate analgesia, avoiding opioids, and explaining to anybody who is currently using them their role in actually increasing pain through central sensitization and encouraging people to move away from them. We don't prescribe them in the clinic ourselves. The PPFA website is a great resource for doctors in particular becoming interested in pelvic pain, because it basically has information leaflets that you and the patient can read on all of this. So I would really recommend that to anybody who might be interested. Again, we talk about the different drivers of pain and the different areas that can be addressed. So neuromodulator is appropriate to the person's medical comorbidities, trying to explain how they work, trying to take the message away that these are antidepressants. That's not why we're using them. As soon as some people hear antidepressants, they don't want to use these medications. So a lot of talking and giving time, and maybe coming back to this at the follow-up visit if they are not keen. A part of the role of the GP in our setup is also to assess for any medical red flags. We don't want to be just managing pain without making sure that nothing has been missed. So if it hasn't been picked up in the intake assessment, it will be in this visit. Hormonal therapies, obviously a key role in suppressing pain for anybody whose periods or bleeding drives their pain. So not everybody needs this, not everybody wants it, but we do try and explain that, you know, as we evolved, we wouldn't have been evolved to have a period every month for decades of our lives, that we would have been pregnant and breastfeeding for a large part of that time, and suppressing periods with medication can be mimicking pregnancy. And if the hormones suit you and don't cause side effects, then they can be a useful option to remove that pain stimulus for everything to settle down, and obviously to treat endometriosis as well. I think the scope of this talk doesn't include going into all the different varieties, but we can and do prescribe all of the things listed there. We have IUD insertions available for anyone who wants them, fully grant funded. So really everything up onto surgery. Again, just reiterating the trauma-informed choice and languages, trying to manage expectations, but also base plans on the patient's preferences, which is really key, and giving all the information at the end. We send letters in this visit to our allied health team, back to the usual GP and to the gynae if they have one, with requests for follow-up of anything that should be more appropriately done in their usual GP practice, so that we keep their care coordinated at that point. And the follow-up visits are usually at 6 weeks and 3 months, but they can link in via email whenever they like. Building the team obviously is a key thing during this session. We have individual and group sessions with both physios and exercise physiologists, and we are now funding a group psychology program, which will be launching in October. We're going to have dietitian education launching before the end of the year as well, which will be online with up to 20 participants to maximise the amount of people that we can reach with that. Additional funded services, we provide TENS machines because we found that even for people who aren't on a concession card or don't appear to have financial difficulties, accessing these extra things like TENS or marina insertions are really barriers to trying them. So the cost of this is relatively small, and they actually provide really good relief to a lot of people. We also provide some resources and training opportunities for our providers. So obviously, you know, we suspected and before we started that there would be a big demand for these services. There are. We don't operate a waiting list, but the wait times are now up to 4 months to see a GP. Resources are required to deliver this kind of care, and PHN have been very supportive in helping us to work out our model. Different team members delivering the same messages is important across the board, and we've tried to link with our nurse and our allied health to ensure that happens. And we need to look at vulnerable group access. For anybody not already working in this area, it is important to know that the majority of patients that we see have one or all of neurodiversity, trauma history, central sensitization, and non-endometriosis contributors to their pain, even when they do have endometriosis. So this is not something that can be done quickly. It does require time, and it does require a team. And we do have to consider workload and well-being, as burnout is a risk in this area. If anybody is considering setting up a model in their own GP clinic, I would say that to have a fillable intake form so that you have as much information as possible before the patient comes in is a good idea. And to use the item 1, 2, 3 if you can. And if that's not possible, if time is not possible, to say up front to the patient that this is going to take a number of visits and chunk it out over visits. The Queensland Pelvic Pain Network is a great place to find some friends to create a team, and certainly a driver for me applying for this grant and developing this clinic was knowing that there were people in the community, physios, psychologists, who I could trust and could refer these patients onto. These are some of the educational resources that we have used to train our team, and I would recommend any or all of them to any GPs and practice nurses in particular who wish to upskill in this area. And there are more resources coming online from other areas, including the Monash University EndoMP project, which is creating a dedicated endometriosis and pelvic pain management plan for use in GP practices. So we welcome connection and collaboration, and look forward to hearing from Marnie and Helena and Katie as we go along. Thank you.
Thanks, Sarah. That was terrific. I'll just check to see if we have any questions and give everyone a second to put any in if they would like. We do have time later on for additional questions. So at this stage, we'll start on with our next presenter. Okay, so our second presenter this evening is Marnie Pointer. Marnie is a physiotherapist and sexologist from Brisbane. She graduated from the Australian Catholic University in 2015, starting her pursuit into the pelvic health field in physiotherapy. Marnie has completed postgraduate training in the treatment of a variety of pelvic conditions that affect people across the span of their lives. And we'll be talking about the services provided under the Endometriosis and Pelvic Pain Pilot. So over to you, Marnie.
Thank you. All right, let me just share my screen. All righty. So what I thought that I would talk about today with everybody was the pelvic pain program that the Healthy Peach Physio Clinic has developed that we're running with Sarah's team for the endo pelvic pain. And so basically just the physiotherapy-led services that we're doing for this. There we go. So the outline of this presentation, or the focus of this presentation, is an overview of our pelvic pain program. And I'll also touch on what we're working on in our individual physiotherapy sessions as well. So the optimal pathway, which isn't always taken up, but we try really hard to get everybody to go through the group pelvic pain program. But ideally, if we could get everybody to start with the program, it makes the individual sessions like way easier and way more useful for the patient. But our group pelvic pain program is 3 1.5-hour group sessions, and we have 6 participants in the session. At the moment, we've been running them in person. And the in-person session, we preferably have everybody like in the room as we're running them. And we're actually launching our telehealth version of the course, which will run exactly the same. So 3 1.5-hour group sessions with only 4 participants, just to make sure that our practitioners can see everybody's faces on the screen and make sure that everybody's cared for using a telehealth sort of format. And we've had really good success, I think, spreading out all the information and practical tips that we can use with everybody across 3 sessions, because obviously it's a lot of information to take in. We've also developed a journal, which is what I'm going to go through with everybody tonight, that basically helps like guide or help people with their pathway to kind of understanding how they got to where they are with their pain, and also like how we're going to journey them out of experiencing the pain and managing it better. And then we obviously have our individual physiotherapy sessions. So everybody who comes to us is funded for either 1 or 2 fully funded appointments to see our clinicians. We spend an hour with them when we see them one-on-one. And I feel like this is a really integral part of kind of making sure that their plan is really appropriate for them specifically. And it works way better if they've come to see us for the program first, because they have all of the good kind of education and information first. And then we follow it up with a more specific tailored stuff towards them. Although the uptake for the pelvic pain program is hit and miss. Some people don't want to do it and they'd rather just come see us one-on-one, which is understandable for lots of reasons. But it does mean that we end up using those individual sessions to do a lot of the stuff that we go through in the course. So this is the first page of our journal, and we basically have developed this sort of lovely graphic in terms of explaining how people kind of make their way into pain and all the different things that are going to contribute to their pain experience. And so we sort of start with saying that there is, you know, our childhood experiences. We obviously have the health experiences of potentially endometriosis or other menstrual conditions. We also have learned like coping strategies that maybe benefited us at some points in our life, but maybe no longer serve us. Things like stress, different life events, just different persistent symptoms or things that slowly develop over time, and all the different sort of learned pathways that this develops in our bodies and in our nervous systems over time. So we go through this this lovely kind of graphic in terms of this is kind of how we got to sitting in your chair, like in the middle of our pain program. This is our pain path out of the pain. So this is what our journal basically leads into. So we start off with basically the knowledge aspect, which I'll go through in a little bit more detail, but we start off with education of all the aspects of pelvic pain that we can kind of share with them. We talk about ways that we can have self-discovery, helping them learn how to rewire their nervous systems, helping them develop new pathways to help manage their pain better, and having a new understanding of how their body functions, having a flare plan for them so that they have a lot more capacity to manage their condition by the end of the course. So in week 1 of the program, we start with knowledge. So the idea of this week is that we go through pelvic anatomy. We try and go through this in good detail, but obviously we don't want to overwhelm our patients with like too much of the sort of nitty-gritty science of anatomy. We also talk about understanding our menstrual cycle. We talk about like the hormonal aspects, and it's probably a bit of a repeat of what the GPs go through when they do their initial intake sessions. But I think it's really helpful for everybody to hear the same messages over and over again in terms of, you know, what's happening inside their bodies and why this is creating the experience that they're having. We then talk about pain. So what pain actually is, the importance of pain in our body and why we actually want to have pain. We just want our pain to be responding differently in our bodies. And then we start off with some practical things in this first session in terms of breathing and body scanning. And we link it all back into the journal that everybody gets to go home to have some sort of reflective thinking. So I've thrown in some of the slides that we have in the program so you guys can all see. So this is our what is pain slide, and it's really important. We've made sure that we're using the same language that the GPs and the EPs and the psychologists will be using so that everybody's hearing the same things over and over again and it becomes really understandable. But basically we're talking about the fact that there are, you know, 3 different types of pains. But pain in itself is this unpleasant sensory and emotional experience. Whether or not it actually reflects that there is tissue damage or not doesn't matter. Pain is pain. We then go on to explain how there are the 3 different types of pain and some examples to really help people understand that they've experienced potentially all of these types of pains in different times of their life. So we talk about this nociceptive pain, which is stubbing your toe, and everybody can kind of understand, yep, I've had that pain before. That pain has told me, you know, I walked too close to the edge of my bed. And then we have our neuropathic pain, which is more that kind of typical nerve pain, electric shooting shock, which might be, you know, sitting on your foot, and then when you stand up and your foot goes dead and you have that sharp, shocking sort of pain that's going down into your foot, that would be a neuropathic kind of pain. And then we talk about nociplastic pain, which is ideally what the entire course is actually sort of focused on, is the idea that our system is plastic, like Sarah said before, and that the pain that we have that is arising with no evidence of actual threat at different points. Obviously, we know that some of these people will have tissue issues, but it doesn't necessarily mean that their pain or the intensity of their pain is warranted. And so this is kind of my the theme, I suppose, that I use when I'm treating pain across the pelvic pain program, our individual sessions, and also just in my private clinic. But pain doesn't always indicate that there is damage, but it does always indicate that there is danger. And if people have this understanding or idea that the tissue of their body is not necessarily why we are experiencing such high levels of pain, but what it really is that our alert system or our pain system is really provocative, and it's telling us that we are in danger and that we need to take action. And I think that once people start to understand the idea of it's not damage, but it is danger, it means that all of the toolkit stuff that we start to work on makes a lot more sense for them. So this brings us to the toolkit. So across the program, the things that we are trying to educate and teach our patients, or the people who are attending the program, is a lot of breath work in lots of different ways. So not just your typical sort of diaphragmatic breathing, which is one type of breathing, but lots of different ways that we can work on structurally using breath to change the way that our body is functioning, the way that our pelvic floor is functioning, and then also different types of breathing that might impact more our nervous system and the way that we are feeling in terms of that sort of sympathetic or parasympathetic states. We run through lots of physical stuff like your stretches and exercise movement, although the program is not entirely focused on the physicality side as that stuff, because obviously we are linked in with exercise physiologists who sort of have their own exercise program as well. We talk about all the psychosocial aspects, so managing stress, sleep optimization, journaling, and then some of the other sort of physical modalities that might be useful, like TENS machines, heat, pelvic floor relaxation exercises, and just reinforcing what the GPs have said about their medication as well. So this is one of our breathing slides. So this is more about the structural aspect of the pelvic floor and the diaphragm. So as we're breathing, we are basically experiencing this descent of the diaphragm, which pushes all of your organs down, and it helps to stretch the pelvic floor muscles, which the pelvic floor muscles like because it helps to bring lots of blood flow to the area. It helps with lymphatic flow. And then as we breathe out, we have this increase or lift of the diaphragm and lift of the pelvic floor. And so it helps the pelvic floor act like this sort of pump action. And the more blood flow that we have and the less sort of lymphatic bogginess that we have in the pelvic floor, the more functional that area is, which is obviously great for our bladder and bowel function, sexual function, and also decreasing the convergence or the amplification that the pelvic floor has on pelvic pain. Our think point, so this is part of our reflection within the journal. So we tried to make it quite practical and really reflective of like the things that they've learned. And so the think point for week 1 is about breathing. We have left space in the journal for each week for them also to reflect on and answer questions in regards to, their own experiences and all the education that we've given them in that first week, and whether anything feels like it has shifted their way of thinking or what their experience means to them. Not everybody takes up journaling because not everybody likes it, but we have that in there for the people who do like journaling. For week 2, we start talking more about the rewiring, and this is a lot more of that sort of the psychosocial aspects of pain. We decided rather than to run with one specific theory of pain or the psychosocial aspects of pain, we decided to run with like 3 or 4 different theories, because obviously it doesn't hit for everybody the same thing. So we used the Explain Pain, Sims and Dims theory, which is from the Noi group. A lot of people find that useful, but for some people, obviously, it's really hard for them to think of true examples of what a safety in me or a danger in me example might be. And so for some people, they just can't get themselves into that activity. So we have that as one of the activities. We also talk about the stress response cycle. So just go to this one. Yeah. So we talk about the stress response cycle, and basically discussing how the stress in our nervous system is obviously going to increase or amplify the experiences that we're having. Our alarm system goes off, and what that means is a heightened experience of pain, on their period or ovulation or whatever has kind of triggered that experience for them. And then we talk about obviously ways that we can complete that stress cycle. We also talk about the window of tolerance. And so I'm sure you've all probably heard about the window of tolerance in your sort of pain reading and everything, but we're sort of talking about the 3 phases. So we can either be hyper-aroused, hypo-aroused, or in this sort of healthy window of tolerance zone. I've found with like taking this course that a lot of people really love this. Like this seems to be the thing that they're really gravitating towards. And I think every time we run it, so we've obviously run it, what are we now, September, like 8 times this year we've run the program. And so I would say most of the time the window of tolerance is what people are really gelling with in terms of understanding how the psychosocial aspects of their life are impacting their pain. And then the bucket, which I think I had back here. So our bucket analogy is basically the idea that there are only so many things that will fit inside of our bucket, and before our bucket overflows. And when our bucket overflows, it's a pain experience. So that might be things like your endometriosis or heavy bleeding conditions, but then it also might be, a fight with my partner or work stresses or family stresses, not exercising enough or exercising too much. And all those things kind of go into your bucket, and before you know it, your bucket overflows. And so we can kind of look at what things could we possibly realistically take out of your bucket so that you're not overflowing that bucket all the time. And so basically this week 2 is all about figuring out what theory is going to hit for these people, and then getting them to understand that basically the psychosocial aspects play a huge role in their pain experience, and what modifiable things do we have, in their bucket or in their life that we can use to help them get back to that window of tolerance. So this is one of the infographics that we have talking about that sort of window of tolerance and practical ways for us to know what it feels like to be in a hyper-aroused or a hypo-aroused state, and then also ways that we can try and come out of that back into our sort of window of tolerance. So really practical kind of way to sort of look at this. And then our week 2 thinkings is basically similar to week 1. We sort of have decided that we need to make it really practical, think back on what we've educated through that week 2 session. And we decided to pick something from all of the different sort of models that we're teaching on, and get them to answer whichever sort of model question that they were really drawn to, that really made sense for them. And then our 3rd week is probably our most practical week. So this is where we discuss ways for us to actually create the new pathways that we need, and also creating their flare action plan. So we talk about sleep because obviously we know it's the, Maslow's hierarchy of needs. Like we need good sleep, we need good social connections, we need food, we need water. So basically looking at, are we getting those things? How can we integrate those things into our life? And then how do I listen to myself and know when I am like on the pathway towards having a flare? What things can I put in place to stop me from getting there? Or if I've missed the warning signals, and I'm in a flare, what is in my flare action plan? Like, how do I get myself out of this sort of position? So with this is one of our infographics in terms of encouraging better sleep hygiene. I can have a little read of that later. We also talk about exercise and its importance, not just because everybody goes, oh yes, exercise is important, like we know that, but really tying it back to their actual period pain. Like, why is exercise important? Because we know when we're in pain, especially when we're on our period or we close to our period, the last thing that we think would be beneficial to us is movement. And we know actually movement is so important in and integral in reducing the the flare. So we talk about the importance of that. And then we go through understanding what needs to be in my pain flare action plan. So looking at, all the triggers that I know leads me down the pathway to having a flare, writing them down so that you can see them. And when you see that you're doing the thing that always leads you down that pathway, being able to kind of go, oh, okay, I've taken on way too much at work. This always means I end up having a flare plan, like a flare. So being able to kind of see the things before they happen. Talking about calming words and support networks, and then things that they've discovered in their toolkit that are really helpful, and encouraging them to re-engage with those things. So this is an example that we came up with that's in the program to kind of help people think about what might be realistic for them to add to their plan. And then our think point is basically about movement. So how did I move my body today? How did it feel when I moved my body today? And just encouraging people to be a little bit more reflective of that. And we obviously know, which is probably beyond the scope of this presentation, but we know about overdoing it in our sort of pain population. When they're feeling good, we do too much, and we have that sort of boom bust or need to pace a little bit more. So this is sort of bringing us back to, how did it feel to move my body? If it felt yucky, like, why did it feel yucky? What can we do about that in that sort of situation? And how do we get you back into moving in a way that feels good for your body? So that's our group program. There's lots of journaling points and lots of reflection. We've tried to make the program as interactive as they would like to be. We've actually been really happy with how interactive everybody has been. So there's been lots of really beautiful conversation, and Claire, the physio who's been running these programs, has been making sure that the program is about sharing what works for people, and making it a really positive program, rather than focusing on the difficulties that people have experienced in their life. So it's a more sort of productive way of communicating with everybody, and kind of developing this little community for everybody, without it sort of feeling like a really trauma dumping space, basically. And then we have our individual sessions. So basically, if they've been through the program, we know that they have a really good understanding of all of the things that we've just talked about. And so then what we want to do is basically figure out, what else do you need? And so at the end of the program, there's like a page that sort of prompts them to tell us more. So, we've taught you all these things, you've put all these things into practice now. What more? What are you still experiencing? What are your kind of questions or your problems that you're still having? Largely around bladder, bowel, and sexual functioning issues. And so what we use our individual sessions for is to basically figure out what's going on for them, specifically in those areas. What functioning issues are they having? And then addressing those. We've also used the pelvic funding the endopelvic pain funding to address pelvic organ prolapse, which we know is super problematic for the pelvic floor. So in the context of pain, is going to be really problematic. So we've been looking at like the entire pelvis, not just pain, and all the things that are going to contribute to that person's experience. And then just individualizing and refining their plan, like pain flare action plan. If there's anything in their plan that hasn't been working for them, or if there's anything not in their plan yet that they haven't tried, we make sure that we try and encourage that. And that's it. If you've got any questions, let me know.
Thanks, Marnie. That was fantastic. We don't have any questions at the moment, but I've seen that a few have been coming through and Sarah's been answering those, so that's great. But we do also have time later this evening to answer questions if they come through. All righty. So over to our third speaker this evening, Keely. Keely Pasqua is a Maori woman working as a research assistant at the Institute for Urban Indigenous Health. She has a particular interest in women's business, with involvement in research and evaluations of programs such as cervical screening, birthing in our community, and now endometriosis. And she's here to present findings of a recent literature review. So over to you, Keely. Oh, just struggling to hear you, Keely. Could you try again? Let's see if we can hear you. sound's not working. I can see your screen there, but it's just the sound.
Sorry, is that working now?
Yes, perfect. Thank
Awesome.
you.
So sorry about that. I'll just quickly share my screen again. Is that showing up?
Yes, it is now.
Awesome, thank you. So thank you all for the opportunity to present today. I'm Keely. I'm one of the research assistants from the IUE team. I'll also be co-presenting with Dr. Helena Clare, who's our clinical director for MATSICHS, and just presenting on an Indigenous model of care for endometriosis and pelvic pain. So before I'd just like to start by acknowledging the traditional owners of the lands in which we're meeting upon today, and also acknowledging those from other lands who are meeting here as well, and also acknowledging the wisdom of elders past, present, and emerging, and really recognising the positive contribution of First Nations people to health and well-being of our communities. So probably late last year, we conducted a rapid literature review just to get a good scope of endometriosis and pelvic pain within Indigenous and non-Indigenous contexts. So this included perceptions as well as practices. And this went on to inform some of the planning and development of the MATSICHS PHN endometriosis and pelvic pain GP clinics, which was in partnership with the PHN. And went on to inform culturally safe and appropriate delivery of care for community. So a bit about our methods. So here are some search engines we use and some words that were included. From our search, we ranked articles based on the level of strength of evidence, as well as relevance to the topic. So this included peer-reviewed articles published from 2015 to 2024. From this, we identified 42 articles relevant, however, none of which were specific to Aboriginal and Torres Strait Islander women with endometriosis. So these findings are quite broad and should just be applied quite generally, and that further research really is needed in consultation with First Nations people. So from articles we found relevant to Indigenous populations, the first one was that we found that Aboriginal and Torres Strait Islander patients with endometriosis or pelvic pain, they might actually express their pain differently to non-Indigenous patients. So they might actually have a lack of expression, they might be non-verbal, it might be shown in the way they walk, due to a range of factors such as intergenerational trauma, religious beliefs, and cultural obligations, for example, priority in taking care of family and working versus going and seeking help for their pain. We also found that Aboriginal and Torres Strait Islander people face significant barriers quite generally in communicating their pain to health professionals. So this, from the patient's perspective, it could be describing their pain is quite difficult. There might be a lot of stigma and shame regarding where the pain or the origins of it. There might be also cultural protocols, such as preferring to talk to another woman versus talking to a male. There might be certain communication preferences, and then as well that general fear of discrimination or receiving low quality care, just impacting them and not giving them enough confidence to speak up about their pain. From the provider perspective, so the patient might have negative past experiences. They might not have a good rapport or trust with the health professional. Depending on the language and terminology used, that might deter them from opening up about their pain. There could be the health provider's tone of voice, their facial expression, and they also might hold false beliefs about pain. So for example, that generally like women are expected to deal with pain, and that if they don't, they are considered weak. Those are some examples. And lastly, our other finding was that Indigenous women among Australia, New Zealand, and Canada tend to have quite low menstrual health literacy. And this is similar to young people who are not Indigenous. And particularly in New Zealand, this was found to be linked to diagnostic delay for conditions like endometriosis. The next finding was that quite broadly, endometriosis has a significant impact on the quality of life and psychosocial health of women. So there's those several domains that are impacted by endometriosis, such as emotional well-being, their quality of sleep, body image, sexual functioning and satisfaction, their relationships, education, work, family, finances, and fertility. And then compounded by that, navigating the health system for sufficient care is quite challenging. And because of this, women with endometriosis are at greater risk of anxiety, depression, and other psychiatric disorders. They also, as a result, tend to have a lower quality of life than women without endo, and they're also more likely to suffer from relationship issues. And we found that similar impacts are also observed in partners with endometriosis, such as that low quality of life and higher risk of mental health issues. The next finding was the significant amount of stigma regarding endometriosis, and some of it in the first quote really stemming from menstrual stigma. So there being stigma about talking about menstrual health and women's bodies, and then other quotes really reflect the stigma in terms of seeking care and bearing with pain and how that affects their access to care. In a broader context, we found that the journey of care for women is really mentally, physically, and financially intensive. So here we identified some barriers to care, there being a lack of trained, knowledgeable, and empathetic health providers. There might be a lot of misdiagnosis or poor pain management. There tends to be quite a lot of repeat surgeries involving multiple consultations. There tends to be a lack of timely referrals to specialists. Resources required to search for diagnosis and treatment are quite large, and there's a lack of support from their partners, family, friends, and workplaces. When it came to enablers in care and receiving adequate care, health providers having knowledge and awareness of endometriosis and when to refer generally helped. Having supportive relationships between the patient and the health provider, things like having a positive attitude, listening with empathy and respect, as well as giving clear explanations. Also incorporating shared decision-making regarding treatment options, so letting women have a voice, and that emotional and financial support from their social circle. We also found that health providers themselves also experience barriers in providing care. There can be minimal training in pain medicine. Consultations can be quite time-consuming, especially when it comes to excluding other causes of pelvic pain. There might be quite complex patient histories, such as trauma, that might delay that surgical diagnosis. And distinguishing endometriosis symptoms from normal menstruation and other conditions can be quite difficult. And lastly, health providers find difficulty trying to manage patients' frustrations, their expectations and reactions to diagnosis and treatment. Our next finding was that current management plans are quite ineffective in managing endometriosis. They tend to be single provider focused, utilizing that trial and error approach. They tend to be quite short term, so running for 8 to 12 months rather than that long-term plan. And they usually focus more on pain relief and fertility preservation rather than focusing on the woman's needs, their values and desires. Some examples might be women really wanting to avoid those side effects of hormonal treatments. In Australia, we found a few plans that women with endometriosis might benefit from. However, neither plans completely remove those financial barriers or provide that integrated care, just because of how many domains that endometriosis impacts in women's lives. When it comes to self-management, we found that as many as 89% of Australian women engage in self-management. It is shown to be quite useful. It does improve their quality of life and it gives them a sense of control over their disease. However, there's a growing evidence that some strategies are effective in reducing pain. For example, cannabis, hemp, CBD oil, heat, dietary changes, and acupressure. However, a recent systematic review actually found that certain self-management strategies are not more effective than other forms of care, for example, hormonal therapies instead in treatment. And so overall, the recommendation was that self-management strategies should be carefully utilised in conjunction with standard care from health providers. Our next few findings was that websites and online resources really have that potential to improve health literacy among women, as well as encouraging health-seeking behaviour and engagement in self-management. The use of web-based resources is actually really common among women and health professionals. However, there tends to be quite a lack of reliable information for both. And additionally, screening tools offer a lower cost diagnostic pathway for endometriosis, but often with more culturally complex populations, they do require that adaptation. And the last slide just touches on some considerations for practice. These were more relevant to within the IUE network. We found that with the workforce, there needs to be that training and upskilling of both clinical and non-clinical staff, just in regards to that pain presentation among Indigenous patients, just because they may not present pain the same way as a non-Indigenous person. There also needs to be that training of staff involved in care in regards to menstruation and other menstrual disorders, just to improve that health literacy among all groups. In terms of health promotion, also improving education in schools, trying to improve that health literacy and really combat stigma, which was found young people tended to have really high amounts of menstrual stigma, and that carried through and impacted stigma towards endometriosis. In terms of kind of media content, it was recommended that there should be more campaigns focusing on stigma and raising that awareness of endometriosis, but also incorporating content for other groups affected by endometriosis, because groups such as LGBTQIA+ and partners of spouses with endo are also impacted. And the next one focused on those tools, so culturally adapting tools for different populations and developing an online website for community to access that anonymously to kind of limit that stigma and encourage them to seek help. Lastly, for service delivery, it was that recommendation of using integrated models of care, just because of how many domains of life are impacted by endometriosis. And then as well, utilising community health workers, such as Aboriginal health and wellbeing workers, or an Indigenous patient navigator as that contact point for clients, just so there's that cultural element in care and being able to really understand and communicate to the patient, and as well help communicate to broader teams about their needs. And lastly, the need for more research and evaluation, just because the findings within the literature, there were none specific to Aboriginal and Torres Strait Islander people. Thank you. I'll hand over to Helena.
Thanks, Keely. I'll just introduce Helena. Alrighty, so Dr. Helena Clare is the Clinical Director for Moreton Aboriginal and Torres Strait Islander Health Service based in North Brisbane. She's worked with the Institute of Urban Indigenous Health for 5 years and has been involved in integrated care projects with Brisbane North PHN and Metro North Hospital and Health Service. She's originally from the UK and was a GP partner where she developed her interest in women's health, and she's practiced as a GP with a special interest in sports and exercise medicine, and has served as a non-executive director on the board of the Hambledon, Richmondshire and Whitby GP Alliance. So over to you, Helena.
Thanks, Amy. Just share my screen. So first of all, thank you, Keely, for your rapid literature review, which was incredible. The work that Keely and the team did, which really provided us with an insight and was integral in the care model that we developed. I just wanted to take this opportunity for those joining us who weren't familiar with the IUE network, just to share some of the background of the work that the IUE network does. So the IUE network was established in 2009 from its 4 founding community-controlled organisations in South East Queensland. On the north side of Brisbane, the IUE network established a 5th clinical delivery service, which is today known as MATSICHS. So our clinics are at Caboolture, Morayfield, Deception Bay, Margate and Strathpone. And the IUE network today services around 35% of Queensland's Aboriginal and Torres Strait Islander population, and approximately 12% of Australia's Indigenous population. So the IUE system of care is focused on trying to address the broader determinants of health, so social, educational, as well as physical health needs. And we do this by providing care in a one-stop shop, which for most of our services is in our clinics. And that creates a safe, culturally safe environment for Aboriginal and Torres Strait Islander clients and their families to come and access those services. Other key services we provide under that roof are dental, allied health and visiting specialist services, such as those from the Metro North gynae pathway, and established through, particularly through COVID, was Moblic, which you may have seen on advertising boards and the back of buses, which really provided a 7 till 7 telephone connector service, as well as serving to link clients who identify as Aboriginal when they're accessing either mainstream GP services or also on discharge from hospital. One of the things we were really fortunate in being able to access when we were designing this services was already some of the existing services that we had within IUE and MATSICHS around women's business. So we're fortunate to have a women's health GP in the majority of our clinics who provide MTOPs as well as those LARC services already. We have a community liaison officer who's the eyes and ears in reaching out to community and helping support clients, particularly those who face barriers in connecting to care. Our women's health physios, pharmacists, OTs, exercise physiologists and psychologists. We also have a senior GP in sexual and reproductive healthcare, Dr. Cara Harvey, who also played a critical role in the development of this service. And she also led the In Our Hands cervical screening programme, which really looked at self-collect as a model for really trying to address inequities in access to cervical screening. Birthing in our community, many of you may know and may have referred to, which provides a midwifery-led birthing programme for women alongside family support workers who walk with women from 0 to 3 years of age for the children, and our social health and family wellbeing programmes. Daily Choices offer a school programme as well, which touched on some of the work that Keely mentioned around the importance of starting education in that early stage. We have a cultural integrity lead who just makes sure that we do remain focused, being community-led, and our wonderful research team who you've heard from tonight. So when we were successful in gaining the funding, one of the things that we did was establish a working group, which really allowed a focus for collaborative yarns to gather knowledge around what we knew about endometriosis and pelvic pain in Aboriginal and Torres Strait Islander women. And that included representatives from the Daily Choices programme, Keely's team, our cultural leads, our CLOs, as well as some of the professionals that we ended up working within the programme as well. And that really just allowed us to sort of discuss and yarn through some of those findings from the rapid literature review, but also some of the key aspects in terms of what the model looked like and what might be culturally appropriate also. One of the things that we hope to be, being community-led, is being responsive to feedback. And we tried to establish a community of practice as well, alongside our Women's Business Shared Pathway and yarns with partners. So this is a brief graphic which shows the model of care that we developed. So as with everything we do at RUE, we place the client at the centre. As per Baden, we placed saw a key role in that wayfinder nurse or sister or auntie, who's really there to triage any referrals that come into the programme, connect with them, and inform and support them throughout that pathway, so they walk alongside them. The clinic assessment which we provide is with a women's business GP and women's health physiotherapist, and to that mix we've also added a psychologist, a female psychologist who, if the client's consents, will provide a third person in the room, but it saves them having to tell their story a third time. And really we found that's a critical role, because many of our clients have had lived experience of trauma, either in childhood or domestic family violence, as well as obviously addressing the impact of living with chronic pelvic pain and central sensitization as well. From that assessment, we can then determine who in that multidisciplinary assessment team may need to play a role. We always, following the clinic assessment, have a follow-up appointment with the women's health physiotherapist. That's usually simply because we have 90 minutes for that initial assessment, but often find that for women who've been on this journey for quite some time, that really we don't even get to the point of doing an assessment. We really just spend the time listening to their journey and the therapeutic benefit that brings. So the other key role, as Keely touched on, is the role of dietitian, and particularly where there's overlapping conditions such as irritable bowel. And exercise physiologists, as also the Baden programme have found that important role of just getting women moving again has been really critical. Where women are looking to either conceive or have been through that multidisciplinary pathway, but still have ongoing symptoms, then that's really where we'll explore onward referral to our Women's Business Shared Pathway, which is mentioned is a pathway that we have in partnership with Metro North Gynecology Services that runs out of 2 of our MATSICHS clinics, and also runs out of the Pine Rivers Community Health Service and Nunda Health Service as well. And we're also fortunate to have a partnership with the First Nations model of persistent pain service for general pain, but also provides a resource for those where we're struggling, particularly around medication, or where there's wider other contributors to pain for those women. This is just some samples of some of the feedback from the early stages of the programme that we've had so far. And just to touch on some future work that we have planned. So we established the programme, the model of care, as a bit of a progressive rollout. And for those who have some knowledge of the endometriosis space, you'll be aware that there's a wealth of organisations and client-facing resources which are out there. And really what we wanted to determine was for our clients and community, which of those resources are actually helpful and useful, and also to determine what they wanted to see in terms of a group-based and peer support programme. So that's underway with, again, with Keely's input and with the benefit of a master's student from UQ supporting us in leading some of those yarns. And the other thing I think we're building on is just looking at building on that rapid literature review and the programme we're developing, and whether that's evaluating it as to whether that's a model that will be more helpful for First Nations women throughout Australia, acknowledging that there's little literature at the moment around that space, and also acknowledging that we're the only community-controlled organisation in Australia which was fortunate enough to be funded for this programme. So that's a little snapshot on how we refer. We do welcome self-referrals, so clients can self-refer to the programme to break down, particularly as Keely's mentioned, where this is considered women's business. So if there's challenges in accessing an external GP, we don't want that to be a barrier. So we welcome self-referrals, and would also welcome referrals for any external GPs also. Also like to just thank Amy for her time and support also in supporting the programme that we've been running as well. Thank you.
Thanks, Helena and Keely. That was a fantastic presentation. So we've got a few minutes left. So if there's any additional questions for our panel of presenters this evening. I did see there was one question in the chat which you've answered, Sarah, but I was wondering if you had any further information you can provide on the acute pelvic pain management guideline, just for any listeners tonight.
Yes, and there's a number of projects underway at state level, state clinical guideline groups, and one of them is a pathway of the management of acute presentations of pelvic pain from the populations that we are talking about here today in ED, but it would be applicable to, paramedics as well. Obviously, sometimes analgesia is needed that is opioid based, and that was the question that was put forward. And it's not that, an occasional use of that is going to be the be all and end all, but the whole point is that if pain was being assessed and managed and listened to and diagnosed and treated properly in the community, less people would end up at EDs. And some of the key messaging on the guideline does relate to pain science messaging, so that pain is real, believing the patient, giving them options, giving them resources and education to move on into that more holistic approach to pain. Unfortunately, what happens not infrequently is that the simultaneous message that your pain is not real, but here are some heavy duty painkillers that won't stop it flaring again. And so that's the kind of message that I want to get across, that occasional use of opioids is not going to be the end of the world, but directing people to services like the two clinics that we've been discussing and other GPs and gynaes with interest in this area would be the main additional factor.
Wonderful. Thanks, Sarah. We have another question. Oh, yeah, Peter's just said thank you. That's great information. We don't have any other questions in the chat, but you are all welcome to send through any further questions if they come to you after this presentation. You can send them through to myself or our practice support email at the PHN. I just wanted to also highlight that it's Women's Health Week. So Women's Health Week runs from the 2nd to the 6th of September, and you can visit the website on the screen for resources and further information on this year's theme, which is celebrating the power of women's choice and women's voice. I'd just like to take this opportunity to thank our wonderful presenters for coming and sharing their time on a Tuesday evening. I know everyone's got busy lives, so it's really important that you came, and we're just so grateful from the PHN, and I know all the health professionals who have attended tonight would be very thankful as well. So that's going to end our webinar tonight. Thanks, guys. Take care.